Welcome to Virtue Podcast, powered by Azkka Pharmaceuticals, India's first company to bring evidence-based flat pricing in medicine. Virtue Podcast brings in renowned healthcare experts as we explore the path to healthier living, where science meets virtuosity. Tune in to YouTube, Instagram, Facebook, and Spotify as we welcome our virtuous guest. Don't forget to subscribe, hit the bell icon for the latest updates, and leave your comments.
Welcome to Azkka Virtue Podcast, where we decode the secrets of well-being with experts who truly care. I'm Bhavin Bhatt, and today we have the privilege of speaking with Dr. Shilanjan Roy, Senior Consultant and Interventional Cardiologist at Charnock Hospital, Kolkata. Dr. Roy has prestigious credentials including MRCP from the UK and FSCAI from US. With years of experience managing complex cardiac cases, he brings a unique perspective on clinical leadership and decision making in modern healthcare. Our topic today is why guidelines don't guide the toughest calls. Despite the abundance of evidence based protocols, there are moments in clinical practice where doctors must rely on judgment, intuition, and experience to do what's right for the patient. Dr. Roy will help us unpack why this happens and how he navigates these challenges in high stakes cardiology care. So, sir, I will move right into the first
Absolutely.
question.
Firstly, thank you, Mr. Bhavin, for inviting me in today's podcast. And I also congratulate Azkka for this, wonderful initiative of creating this type of podcast with the physicians and not only discussing on the academic topics, but also various other healthcare related important aspects
Right.
that also are very important in the overall care of a patient. I can see that today's topic is also very interesting and intriguing, that how guidelines don't guide us in making the toughest call. In fact,
Absolutely.
we are, have an idea that guidelines are there to guide us. But in many cases, there are situations, clinical scenarios where we have to deviate from the guidelines, or guidelines do not navigate us through those difficult situations.
Very true.
So it's quite interesting. Let us see what you have in place for me.
You're
What are
right.
the questions?
And sir, it is our pleasure to have you for the interaction because we truly understand, how difficult it gets for a cardiologist of your stature to make time for this and
No, that's okay.
take time out for the viewers and the
Yes.
listeners, majorly for patient awareness, which is very much important in these days. So, sir, welcome to the Ask a
Thank you.
Virtue
Thank you very
podcast.
much.
So, sir, moving right into the first question, to loosen up
Hmm.
the things a bit, uh, let me ask you, sir, that if you were not a doctor today, what you would have been?
So from very childhood, I actually wanted to become a doctor only,
Hmm.
and so that was one of my, goals and my aspirations. That when I grow up, I will become a doctor. So that was a dream fulfilled when I first became a doctor, and more so, I wanted to become a medical specialist.
Right.
If I were not a doctor, probably I would have been. That's another passion of mine is teaching. So I would have been maybe a teacher or professor in one of the colleges, teaching
Okay.
some subjects to my students.
Okay.
And also, I like singing a lot. I like listening to songs and singing. If I was maybe trained singer, I could have thought about pursuing singing as a career also.
Wow. Okay. So, sir, I would say that it is pretty fascinating to see that you have become what you wanted to be, but at the same time, you also take out some time for the hobbies, as you said, and
Yes.
which is absolutely needed for the
Mm,
kind of
absolutely.
career in which you are into and the kind of high stress
Mm.
job that daily, encompasses the everything. So, sir, what's something most people don't know about you is what I would like to bring out here. Because usually, what happens in a clinical or hospital setup when a patient sees you or the family, they never get to understand the doctor's different side. They only see that serious side of the doctor. So, Let me ask you, about your hobby or your hobbies or hidden talents which you would like to share.
And I can say in my clinic also, or in my OPDs when I deal with my patient, I try to be myself. So I
Right.
deal with the patients with, uh, what I am. So that helps me to, I mean, gel with the patients more, to make a good rapport with the patients. That helps us to deliver a better patient care, also to counsel the patient well, to understand the patients, what patient is, exactly wants from me, wants
Right.
me to make, counsel them. So I try to be myself, don't
Right.
pretend to be very serious in hospital setting also.
Okay.
And regarding my hobbies that you asked, I definitely like a lot listening to songs, different types of songs, Bengali songs, old Bengali and Hindi songs, even the new generation modern songs I like a lot. At times when I get some time, I like singing also a bit. So that's,
Wow.
sort of stress buster for me.
Right.
Reading to different types of books, particularly the very classical type of Bengali books, Bengali literature,
Okay.
that I like a lot. Though nowadays I don't get much time for
Hmm.
reading books, but whenever I can make some time, I usually listen to songs. Even after a hectic day, I usually spend some time listening to songs, different types of songs.
Right.
If I get opportunity to, I sing also at times, some
Wow.
record some songs. So these are some, areas of busting
Hmm.
my stress, or
Right.
some of my hobbies that I like to pursue in my busy schedule also.
Wow. And I really love that. It's such a great reminder that even in high stakes profession like yours, creativity and fun can also
Yes,
coexist.
absolutely. So
Absolutely.
whenever there is creativity, whenever there is, creative pursuit, it helps you to, pursue your day-to-day activity with a more, fresh mind.
I agree.
Huh?
You
That
feel rejuvenated.
absolutely. So
Yeah,
helps you to rejuvenate, and gives you a more zeal to pursue your day-to-day activities with, renewed interest and renewed vigor.
absolutely. Great to hear that, sir. So, Dr. Rai, you have extensive experience as an interventional cardiologist across India and internationally. In your view, uh, what do you think that clinical guidelines often fall short when dealing with real world critical decisions?
Yes. Now, clinical guidelines are there. It is for various diseases of various specialties. The guidelines are actually set of, I mean, mm, some, you can say, some expert mm, opinions,
Hmm.
that is primarily derived from data, scientific evidences, which generates from the randomized clinical trials, from various meta-analysis. The experts, they analyze the data and they derive the guidelines that how to
Right,
treat a particular disease or a particular condition more effectively. What should be the ideal way of approaching a particular disease? What should be the way to diagnose it, treat it, so that clinicians get an outline of for a treatment of a particular disease.
right,
It particularly, what it helps, firstly it helps the clinicians to get an idea regarding treatment of investigation, diagnosis and treatment of a particular disease. Secondly, it aims to reduce the variability in the treatment, so that there is a uniformity in treatment for a particular disease. Suppose we are treating a
right,
patients of cardiac disease, a heart failure patients. Heart failure guidelines helps us all across the globe, all the cardiovascular physicians, to maintain a basic standard of care whenever you are treating
correct.
heart failure patients, to
Hmm.
reduce the individual variability, and to maintain a good standard of care. So
Right,
it's imperative that guidelines are very much important in nowadays present day evidence based medicine care for proper treatment. But there are some, shortcomings of the guidelines also.
true.
Firstly, guidelines are mainly derived from the very controlled, selected patients who are enrolled in the randomized clinical trials,
Right,
and they do not at all times reflect the real life clinical challenges or real life patients that we deal
hmm.
with day to day.
Right,
So real life patient or any patient, they comes to us with unique characteristics, with their unique problems, their unique demographics, everything. So each patient is like a, blank page of a new book. So you
true.
have to
So
you have to treat a patient in a very personalized, tailor-made approach. Guidelines can only give you a basic idea or an overview or a framework that how to approach for that particular case.
Absolutely.
But a patient is not treating a case, it's treating the patient as a whole. So you have to see the patient's demographic, which strata of the society the patient is coming. What is the patient's access to healthcare? That is very important,
So
because
true.
guidelines don't tell us that they do not differentiate between the different the patient's access to healthcare, which is very
Right.
important in our country like India, where all patients do not have similar extent of access to healthcare. A
Right.
patient who is living in a metro city, in a big city like Delhi, Mumbai or Kolkata, access to tertiary care healthcare or advanced healthcare facilities, and a patient who is coming from a faraway village only have access to very primary healthcare
Very
setups.
true. Very true.
So treating same diseases in these two different settings doesn't hold, we cannot follow the same guidelines or same very strict guideline recommendations. As a physician, we might have to slightly deviate, slightly modify our approach when we are treating patient in different settings. So
Right.
whenever I will treat a patient, suppose a cardiac patient, in a primary care setting, in a faraway village, in a primary health care, or maybe in a district headquarter hospital, and the guideline, the outline of treatment or the way I treat a patient will be entirely different when I'm treating the patient in a high-end tertiary care hospital.
Right.
So it is not only guideline that will dictate us, but also the available resources, the logistics that is available in that particular setting, that will also help us to choose that what clinical judgments or clinical decisions, treatment decisions will take. It also whenever we are treating a patient, we have to take into account multiple comorbidities of a patient. So
Very
a patient will come to us, all patients would come to us in a single garden variety of patient.
Right.
Multiple patient will have got multiple comorbidities. One patient will have got he may or she or he or she may have got multiple chronic conditions like diabetes, hypertension, kidney diseases with them. Some patients may not have these comorbidities. So presence of these different other ailments, comorbidities, that will also dictate that how we'll treat the patient or modify the treatment guidelines while we are treating that patients. It also depends upon the individual treatment preferences also. So we have to give respect to the patient choices. That is very important.
Right.
So some patient may not be willing for some particular therapy. A particular therapy, a particular procedure, particularly invasive procedure, operative procedure, that may not be acceptable to a patient. Patient may refuse that particular therapy. That doctor, I am not willing for that. You are telling me that this invasive therapy, this particular operation is good for me, or it is guideline recommended, but at present I am not willing for that particular therapy. You do something with medicines only, whatever you can do.
Right.
So whenever we have to give importance to the patient preference also, we cannot just impose a particular therapy on a patient that this is the guideline recommendation, you have to abide by this only.
Absolutely.
We have to absolutely respect the patient autonomy. We have to respect the patient choice, and accordingly we have to modify our treatment options. But keeping in mind that we should not make any harm to the patient, or at least even within the available resources, we should choose the options that will give maximum benefit to the patients.
Right. So, sir, as I understand that guidelines are basically a framework.
It's absolutely a
And-
framework. It's an outline.
Right.
It will guide you, but
Right.
it should not absolutely be bounding to any physician or to a clinician.
So within that framework, for every individual patient, there will be a tailor-made approach.
Tailor-made approach, absolutely. That is the
Depending on
crux of the
Right.
entire discussion today.
Right.
That guideline will only guide you. It's like a
True.
compass that will guide you through navigating through an uncharted sea.
Right.
But in the course, when you are dealing with a particular patient, you will come across various patient-specific challenges that you have to deal with your clinical ideas,
Experience.
intelligence, experience, and acumen. So
So
here lies the importance of your clinical abilities and clinical intelligence, I can say.
Wow, that is very rightly summarized. That we often think, that guidelines as the final word, but it's clear they
Yes,
are just the beginning of the, conversation when real life
real life
complexity kicks
situation
in.
begins. So
So,
whenever a patient comes to you, sits in front of you in the clinic,
hmm,
it's not the guideline
right,
only that dictates you how you treat the patient.
so
You
true,
have to treat the patient holistically.
right,
Guideline is only one part, that this patient has got this particular disease. Guideline recommend us that this is the best possible treatment that I can offer
hmm,
to this patient. But
right,
I told that multiple other factors will be there in place.
right,
You have to think about the patient cultural background, patient preferences, patient comorbidities,
so true,
okay, patient maybe uh, access to patient's health care. If the
hmm,
patient is coming from a faraway village, very remote area, no access to healthcare, no access for monitoring also,
right,
because some of the advanced therapies, some of the advanced medications, they require constant monitoring of the patient condition also, by
hmm,
means of maybe regular blood investigations, some regular investigations, which not be accessible to all
right,
at all to that particular patient.
true,
So we cannot advise that particular medicine or particular therapy to that patient.
right,
Suppose patient has to undergo a particular blood test every 7 days
hmm,
while on that therapy,
hmm,
or some particular investigations while on the particular therapy or medications, but patient do not have access. Patient tells me that, doctor, I can take the medicine, I
hmm,
can purchase the medicine, I can take the medicine, but I don't have any labs or any access for that
right,
checking.
right,
So once the patient do not have any access to that particular investigation, checking option for investigation or monitoring, I
hmm,
cannot advise the patient for that
right.
particular therapy. It
So
may be rather
approach changes
without
completely.
without monitoring that therapy, rather may be harmful to that patient. So
So
in that
true.
case, I have to modify my therapy. I might
Hmm.
have to modify the drug doses, or how give the combination of medicines. Everything changes according to
Right.
the patient's access to healthcare also. So that is very important.
So true. So true. So, sir, how do you balance evidence-based guidelines with your clinical intuition, especially in complex or borderline cases?
So mainly the problem arises in complex and borderline cases only, because in guidelines, because they are derived, I told you, it
Hmm.
is mainly derived from the data or the information that we gather from the randomized control trials, the
Right.
big trial settings. Multiple thousands of patients are being enrolled in large trials. From there we deduce the references, the positive findings or the negative findings, whether a particular therapy, particular uh, procedure, particular medication is effective for that particular patient population or not.
Hmm. Hmm.
So for any RCTs, there are certain strict laid down inclusion and exclusion criteria. Whenever we are designing, or a trial is designed, a randomized control trial, which is the essence of
Hmm.
today's generation evidence-based medicine, that everything should be derived from a randomized trial, which forms the highest uh, level of evidence,
Hmm.
or the highest, it's placed in the highest in the hierarchy of level of evidence. Whenever a RCT is being designed, the first thing is that to decide the inclusion criteria and the exclusion criteria of the patients,
Patients.
that
Right.
which patients are to be included within that study, which patients are to be excluded
Excluded.
from the study.
Absolutely.
So they follow a very strict criteria
Hmm.
regarding that. Only the patients who stringently falls into the inclusion criteria, they are being included into the study. And a large proportion of the patients who may have the disease or might having the same disease, but they do not fulfill the inclusion
Inclusion.
criteria, or they fall into the exclusion criteria, they're excluded from the study. That
Right.
does not mean that they are not having that disease, or they are not candidate for that particular therapy. So trials are designed in such a way to
Hmm.
select patient who are potential candidate to get the maximum benefit for that particular study. So
Right.
in the basis only, whenever we are designing a randomized control trial, there is some bias that we
Hmm.
are excluding the patient who are, less likely to get benefit from the study. But that
Right.
does not mean that these patients are not candidate for that particular therapy. They might also get benefit, but they are,
True.
excluded
Excluded.
excluded from the study population, and
Right.
that forms a very big proportion of that patient pool also. So
Hmm.
whenever in clinic we get this type of patients that do not exactly fit into that particular inclusion criteria of a randomized control trial,
Hmm.
we fall into a dilemma, that
Hmm.
whether we offer that particular therapy to that patient or not, because
Right.
we know, or in the back of the mind we have that idea, because this particular patient subset was not included in the study.
Right.
But my clinical intuition tells me that with the patient present condition, that therapy might be beneficial. So even it may not be absolutely guidelines supported. To some extent, I have to go off level to introduce that therapy with, proper explanation to the patient. Exactly. And it is actually a shared decision making that is extremely important. So you have to have a shared decision making, a thorough discussion between the patient and the clinician, that we are introducing or we are thinking about this particular therapy or procedure for you, that you are not exactly eligible as per the guidelines, but as per our understanding, it might benefit you. It might not benefit you also. So exclusion does not mean that it's not going to give you benefit. So evidence is not there. Evidence is not there does not mean you are not going to get benefit from that therapy. For particular patients, we can we at times we have to use certain therapies which may not be outside the guideline but may be beneficial to the patient. So this decision is a difficult decision that as a clinician we have to make, and we have to navigate across those challenges. So shared decision making, having a clear clinical idea that which patient might benefit from that particular therapy, even though certain parameters or certain conditions that have made them excluded from that particular study group, or they may not fit in exactly, but still may be beneficial. So accordingly, we have to go with the guidelines. That I already told you, it gives us a framework. It gives us a overall, what I can say, a roadmap how to proceed. But it is not the absolutely, the gospel truth or the, sacrosanct thing. We have to modify at every point when we are dealing with a real life patient.
Right. So I really appreciate, how you framed that. It's not about choosing between data and instinct, but knowing when to let experience refine the evidence. So that's a skill very few talk about, but many rely on. So I completely understand that. That is where your clinical experience would come into play. So, sir, as a senior consultant, how do you mentor junior doctors to develop the confidence to make tough calls when guidelines don't fit in? Because what usually happens is at a senior level, yes, it becomes because of the clinical experience they have, it becomes relatively easier to take decisions. But how do you mentor your junior doctors?
Yes,
in
for
such
juniors or
situations?
those who have just passed, just starting their specialty training, it definitely it's a tough call. So my advice to them is usually or will be that more or less you try to restrict yourself to the guidelines and evidence-based medical practice. So what they will, what that will do, firstly, they will be confident that they are going by the guideline-based therapy. So that they are not, widely deviating from the standard of care. So that will give them confidence, and that will also protect them medico-legally also. Because if you follow the guidelines, that is always an additional benefit or advantage, that if you fall into some problem or there is some untoward, some untoward incident happens, some bad things happen, you will get some medico-legal protection, that at least the doctor had followed the guideline or evidence base according to the course of the treatment. And so possibly, but untoward things do happen. So he will get a medico-legal backing, support. If it, as a junior doctor, does something very, experimental, very aggressive, very, out of the box, and the result is not good. If the result is good, everything falls in place, then it's absolutely fine. You are away with everything. But if the outcome is not good, if the outcome is adverse, then the junior doctor can fall into some problem. So that is one caution, that better to stick by the guideline. If any particular emergency situation you feel that particular patient is not fitting to the guideline, or you are not very confident that how to deal with that particular case, seek your senior's help immediately. That is the thing. Don't take some decisions in a rush or hurry. Very aggressive decisions. You take help of your seniors, take opinion of your of the experts, and then go by it. So there is always opportunity to, or there is option of taking help There is no
Right.
point or no point in showing your heroism and heroics while treating a patient,
True.
particularly in emergency scenario. You
Right.
always need a second brain who can think more
Hmm.
clearly, and can guide you or navigate you through that challenging situation.
So that's such a great approach, that creating space for vulnerability in medical training could be the key to shaping better and braver doctors. Uh, very rightly summarized, sir. Uh, so, sir, how do you personally cope up with the pressure and responsibility of making these difficult decisions? Because I'm sure that when it is actually happening, those few minutes or moments are so critical.
Yes, absolutely.
So that time, how you actually cope up with the entire thing?
Yes, that's also, always a very difficult and tough call for a senior doctor also. That in two scenarios. One will be an OPD scenario when we are, seeing a patient in your clinic or chamber. You have got time, you have to think, you can think clearly, you have got time to discuss with the patient relatives. The point that I told you, that's very important while you are dealing with a particular patient, is a shared decision making
True.
or informed decision making, that you have to discuss about everything, that this is the treatment options that we have, or this is the guideline recommended treatment options. But for your particular, because you have got these comorbidities, you have got this kidney problem, you have got this long duration diabetes, or you have got,
Hmm.
for a very old patient, frailty, life expectancy, all these things matter, regarding choice of a therapy. So that we have got time to discuss, that for you we have got these things, these options, we have got medical options, surgical options, all these things.
Right.
For me, or from my judgment, I think that this will be best for you, or for a patient relative,
Hmm.
to discuss them, that for patient, I think this option will be best. It may not be very prudent to go with a very high end sophisticated invasive procedure at the age of 80-85 years.
True.
We can go with a more conservative approach, medical therapy, give
Right.
him a more soothing, a palliative sort of care,
Hmm.
reduce their discomfort. Because at the age of maybe above 75-80 years of age, very aggressive invasive procedure may be more harmful for the patient.
True.
The same scenario may not be just the reverse in case of a young individual, 40,
Hmm.
45, 50 years of age,
True.
who is going to get benefit from a new age modern invasive procedure to
Right.
give him a more more productive life
True.
and greater longevity. So for that particular patient, I might recommend that this high end procedure, this complicated invasive procedure, though these are very new therapies, but
Hmm.
that is going to give you a benefit. So it's a sort of personalized decision making, tailor
Right.
made decision making, depending on the patient's age,
Hmm.
patient characteristic, all the comorbidities that the patient is having, life expectancy of the patient, the expectancy of the patient himself, that what the
Hmm.
patient, how much the patient wants, accessibility to care that I told you. So
Right.
all these factors comes into place while determining what will be best for my patient. And
True.
definitely guideline is there to guide us, not to
Right.
dictate us. That is
Absolutely.
first thing. And second part, that as a cardiologist we face day in and day out, that is dealing an emergency situation in a cath lab. So
Hmm.
whenever we are doing some interventions, maybe in a cath lab, and we face some challenges,
Hmm.
some complications in the cath lab, that also becomes a very challenging situation for all of us as a cardiologist.
True.
So that time, the first and the foremost thing that comes to our mind is not to follow guidelines or what will be the best outcome for that particular intervention. The first will be to bail out the patient, to save the patient life. Even we will be happy with a suboptimal outcome of that particular
Hmm.
procedure, but the first and foremost idea
Hmm.
in our mind will be not to create any harm or damage to the patient, to save the life of the patient first,
Right.
because we can fix that suboptimal result later on. Suppose we are doing a
Right.
stenting in a
Hmm.
coronary artery, and we feel that the stenting could have been better, could be more optimized, but
Hmm.
at the same time the patient is experiencing hemodynamic instability,
Hmm.
patient is experiencing some other problem, and we feel that the patient can go worse in short
Hmm.
time. So it will be better to cut short the procedure time,
Right.
make it brief, come out quickly,
Right.
stabilize the patient first. Then after maybe after few days or few weeks, we can, I mean,
Hmm.
again give it a retry to optimize the procedure. So
So
patient
true.
safety, good outcome, patient's life is of utmost importance when we are dealing with a medical emergency, and there is no point in thinking about what guideline teaches us about optimizing the outcome. It's always the patient's safety and life that is above all the guidelines, that we have to keep it in mind and do it accordingly.
So true, so true. It is so grounding to hear. It shows that every seasoned doctor don't just rely on skill, but also on mindfulness. Such a powerful blend it is.
Yes, absolutely.
So
It's a reflex, clinical reflex, your acumen,
so true.
hindsight, that is very, very important. At times, another point very interesting that you will be very, fascinated to know. At times, results can mislead us. The diagnostic result test can mislead us. I have come very recently through some experiences where I have got some results, some imaging results that that showed me a very normal result, normal looking result in a patient. But my hindsight, my from the history of the patient's clinical complaints, there was always, I was thinking that something is wrong. The patient's complaints, the patient problems, it's not matching with a normal result. The results cannot be normal. Blood results and the radiological investigations cannot be normal. So I insisted the patient to go for an invasive investigation like coronary angiography. And unfortunately, or fortunately maybe for the patient, that the results came out to be very serious. Serious blockages came out in the coronary arteries, and the patient required even bypass surgery. A couple of my patients required bypass surgery. Well, CT coronary angiography was showing a near normal report. One of the patient required a very complex, I had to underwent a very complex angioplasty report. So it was the patient's symptom, the patient problem, and my clinical judgment that dictated me, even with a normal report, tell the patient that though your report is showing normal, but I feel that something is wrong, something is not fitting. Something is not properly fitting into the thing. So better you go for a invasive investigation, though it is invasive, but in my judgment, it is better to go to get a more clearer idea. And unfortunately, or more fortunately for the patient, because if I had neglected and relied on the those reports only, it could have been a catastrophic result in the future. Patient have had a sudden cardiac death also. So more invasive investigation in that case, backed by my clinical judgment, came as a boon for the patient, and patient could get the therapy and now living a normal life.
Wow. So, sir, at this stage of your professional journey, where you have treated thousands of patients, uh, what will be that advice you would like to give to young cardiologists?
So, the same point that we have discussed across the course of this very interesting podcast, that guidelines are there to guide you. It's a framework to guide you across, how to treat a particular disease condition. But it is not about how you will deal with a particular patient. Treating a disease and treating a patient is not similar. You have to treat the patient as a whole in a more holistic fashion, keeping in mind multiple factors, not only his disease condition, not only a particular diagnosis. You are not treating a diagnosis, you are treating a patient as a whole. So whenever you are treating a patient, guidelines will definitely be there. It will guide you regarding the choice of therapy, regarding the best possible, the evidence-based updated therapies. But at the same time, you have to respect the patient autonomy. You have to respect the patient choice. You have to keep in mind the importance of shared decision making or informed decision making whenever you are embarking on a procedure, particularly invasive procedure. You have to think, keep in mind the patient access to healthcare, how much the patient is comfortable or able to abide by the necessary follow-ups and the investigation that a particular therapy requires or mandates. If it is not possible, you have to make some modifications. You have to think about the patient ethnic background, the cultural sides, patient diet, everything. It should be kept in mind. So it's about holistic care that every young physician, young cardiologist should keep in mind, and guidelines, medications, invasive procedures, surgery, everything will go hand in hand to give that particular patient the best possible clinical outcome. That should be your aim.
Wow. Sir, let me tell you, I must really appreciate, the way you have made it so simple to understand. I'm sure not only for doctors, but listeners as whole, that, uh, it is all about your mindfulness, your clinical experience, and
Yes,
the framework of guideline within
guideline.
which there has to be a tailor-made approach for each and
Each and every
individual
patient, absolutely.
patient that comes to you. And so this is such nicely articulated. and I'm sure will be really appreciated by all the listeners, patients, and the
I
young
hope so.
doctors
Hope
and
so.
the medical fraternity. So, sir, before we come to the end of this interaction, lovely interaction, I would say, there is something fun which should not miss. We have been
Okay.
hearing about all the talk shows have rapid fire rounds.
Mm.
So we
Yes.
thought, why not take that liberty
Okay.
and have a fun session with
Okay.
the doctors?
Okay.
So, sir, are you ready for the
Yes.
rapid fire round?
Yes. Please
Here
proceed.
we
I
go.
am
Here we
absolutely
go.
ready.
So, guidelines are always enough. Fact or myth?
It's a myth.
Okay. Has Bengali writer or any other role model shaped your way of thinking in medicine?
Uh, Thinking in medicine, I think some writings of Bidhan Chandra Roy,
Okay.
some writings of Bonoful, Bolaichat Mukhopadhyay, who himself was a doctor. His, very famous novels like Ognishwar, which has been adapted in a movie also. So
Hmm.
it has largely,
Impacted the
impacted
way of
me
thinking in
the way of
medicine.
thinking also.
Wow. One procedure you think will become obsolete in 10 years from now?
In fact, procedure cannot comment, but I think very soon with the advent of AI and all those advanced gadgets, stethoscope is going to get obsolete very soon, or the need of stethoscope. It might be a sort of ornamental thing for the doctor, but
Right.
the practical utilization and implication of a stethoscope is gradually getting very low.
Oh, wow. Your clinical philosophy?
My clinical philosophy is always, think for the patient first, patient betterment, and primum non nocere, that is, do not harm the patient, do not show your heroics. Medicine is not a place to show the heroics of the doctor, rather
Right.
it is for the, good for the patient. So choose wisely in a clear mind that what will be the best for the patient, and take your judgment accordingly.
If every Indian adult followed one rule, heart attack rates would drop drastically. What, according to you, should be that one rule?
One rule will be to stop smoking for all the smokers, particularly. Smoking and taking tobacco, one of the strongest modifiable risk factors. So, all the Indian adults who are smoking, if they can quit smoking, we can hugely reduce the risk of cardiovascular diseases, particularly in the young. And definitely going for routine blood screening at a younger age, so that we can pick up hypertension, diabetes like strong risk factors early, so that we can control them, treat them properly, so that that does not lead to cardiovascular diseases, because these are the strongest risk factors that Indians are having. Indians are becoming, the diabetic capital of the world, the hypertension capital of the world. So much of prevalence of hypertension, diabetes, and that is particularly contributing to this huge burden of cardiovascular diseases.
It was indeed rapid and with a lot of fire.
Hmm.
So, as this brings us to the end of the interaction, sir, what we have heard today is a powerful reminder that medicine isn't just about following a protocol, it's about treating a person. And in those toughest moments, it's the clinician's judgment, experience, and courage that truly guide care. Whether you are a young doctor learning to trust your instincts or a senior physician mentoring the next generation, this episode was for you. To all our listeners, trust the science, yes, but also value the human behind the stethoscope.
Absolutely.
This was another meaningful conversation on the Azkka Virtue podcast. Until next time, stay curious, stay compassionate, and keep listening. Thank you, sir. Thank you for your
Thank you
time.
very much.
It
Thank you
was
very
such
much.
a pleasure to have you, sir.
Thank
Thank you
you.
so much, sir.
Thank you.